and discuss them. And we'd be very happy to answer any questions at all. Okay. So this really is what the talk is about. It's about really what's happened and what a stroke is, because that relates to the sorts of medicines that we often have prescribed. And it also then goes on to discuss how your community pharmacy can help you. So let's think about strokes really, and a few statistics first of all. So every year there are approximately 100,000 events, stroke events. So that means that in this country, someone is having some form of a stroke every 5 minutes. It's an incredibly common condition, but one often that, of course, we give really little thought about until either it happens to ourselves or someone that we know or someone that we love. There are over 1 million people in this country surviving having had a stroke. But because having a stroke is an indication that we are at risk, almost a third of people who have had some form of stroke, be that a large major stroke or a mini stroke, will go on to have another stroke episode. And that's another reason why it's important to have the medication that we're going to discuss in a little bit. Now, we think of it as something that occurs to us when we're old. And that's true to a degree. It is more common. Increasing age is an increasing risk. The sort of the rough age is generally between 40 and 70 years. Nearly 40% occurs, but most people it's around 70 or older. Having said that, it's not only a condition of old age. Tragically, uh, 1 in 150 people under 20 years of age have a stroke, and even young children can experience a stroke, tragically. And it is a very dangerous and a very nasty disease and a nasty condition. It kills twice as many women as breast cancer, for example. And yet, as the stroke charities will explain, the money that goes into stroke research is much smaller than that goes into breast cancer for all sorts of reasons. Obviously, breast cancer is a very emotive condition. So, what is it? When we talk about a stroke, what do we actually mean? Well, you may have come across all sorts of different terms and conditions, and you may have seen any number of these. You may have heard them discussed, or you may have seen them on discharge letters that you receive. But fundamentally, a stroke is just one thing. It's loss of blood to where the brain needs it. It's a serious, life-threatening condition that occurs when blood supply to part of the brain's cut off. The brain, like every other part of our body, requires oxygen and requires nutrients and requires other chemicals in order to operate and be healthy. And if it doesn't get the oxygen and it doesn't get the supply of nutrients, then those cells will very shortly die. And so, if the blood supply is cut off to the part of the brain, those cells that are not getting the blood supply, they're no longer working. And consequently, we get the symptoms that we do with stroke. Now, there's two types of stroke, and you can divide them pretty much into two types. The less common, about 20% of people will have had a bleed, which is referred to a hemorrhagic stroke. Hemorrhagic like hemorrhage, which we're familiar with. And that's where a blood vessel may burst or tear and there's a bleed. And that blood then will sort of put pressure upon that part of the brain where it's leaking into. But more importantly, of course, blood's not getting to that part of the brain. The other type of stroke, the more common type of stroke, is the blockage type, where a blood vessel, either a large or a small blood vessel, becomes blocked, and so blood can't get through. And I often use the analogy of the heating system in my house, and I live in quite an old house, so it experiences both of these problems. But when my heating system's working well, there's a pump at my boiler, which pumps water around my heating system, just like my heart is pumping blood around my body at the moment. But we live in a hard water area here in Bristol, and so my pipes start to fur up. And if my pipes fur up, especially if I lived in a house that had the very tiny micro bore pipes, very quickly they fur up and water can't get through. So that radiator gets cold, it doesn't get the hot water. Equally, if I have a leak in one of the pipes and water's pouring out, again, it's not going to get to the radiator and the radiator's not going to get hot. But it's exactly the same with the blood pumping around the body. Those two things can happen to us as well. And the consequence is blood doesn't get to where it needs to be. So the other type of stroke that sometimes get talked about, this transient ischemic attack. So that just transient just means it lasts for a limited amount of time. Ischemic means that it's the blockage type. So a mini stroke is the blockage type of stroke that doesn't last very long. Typically, the symptoms will not be long. So as I've said, it's the blockage type. The symptoms of a mini stroke are the same as those of a major stroke. And the only difference is that we appear to have some recovery, or possibly we think that we've completely recovered. So, very typically with a mini stroke, the first thing that may happen that means it's recognized is that we may fall because we may lose the use of one side of our body. So we lose the use of one leg, and so we fall to the ground. And often the first time that a mini stroke is diagnosed is after we've had a fall. The thing about a mini stroke is that it is a stroke. It is important, and it's really important not to ignore it. So if you or a friend have something that may have some stroke-like symptoms, or you have an unexplained weakness on one side that doesn't last maybe more than half an hour or maybe a couple of hours, it's important not to dismiss it and not ignore it. And it's important as any other type of stroke. So we've talked about being at risk. What are the risks really? Well, the bleed type of stroke, this is the hemorrhage. Yes, it's the less common type. As I said, about 20% of people who have a stroke have this bleed type. The main risk for this is uncontrolled raised blood pressure. And that's one of the reasons why every time we see our doctor, there's talk about blood pressures, talk about measuring our blood pressure, about monitoring our blood pressure. And even if we're taking blood pressure medication, we still have to report our blood pressure findings. It's if we have uncontrolled raised blood pressure, it's putting a strain upon all parts of the body. It's putting a strain upon the blood vessels, just like those sort of party balloons, the long, thin party balloons, which you may have seen people make balloon animals with. When you blow into them and you blow hard, you get that little bulge comes out. And that little bulge can be a weakness. And just like any other balloon, that little bulge can burst. And that can be that risk. Equally, uncontrolled raised blood pressure, it's pushing harder through our organs, harder through our kidneys, harder through our livers. And it's just like me driving my car in second gear everywhere. I can do it, but I'm going to wear the engine out that much faster. And so that's why controlling raised blood pressure is very important. But then there's other familiar risks. So risk of stroke, particularly the bleed type, is much increased as we get older because blood has been pushing around those vessels for maybe 60, 70, 80 years. Being a man, we have slightly increased risk. Heavy alcohol use, particularly excess alcohol, unfortunately, does a lot of bad things to the body. There's genetic components, so people from black or certain minority ethnic groups, such as Asian ethnicity, carry a higher risk of having a stroke. And that genetic risk also comes down from our family as well. So if our parents particularly had heart or circulatory disease at an early age, then we are more likely to as well. And pregnancy too carries a risk of stroke because of the strains and stresses upon the body. So then there's the blockage type. So the blockage type, 80% or more is the most common. And as you can see from the little diagram I've put there, really you get a blockage in that vessel. And the blockage in our blood vessels tend to be the fatty deposits. And the fatty deposits which are laid down the cholesterol and other fats which go around the body, and most of which is actually produced by our liver. Because it's important, those fats, cholesterol and the other fats are important for the functions of our cells and the functions of our body. That's why the liver produces them. And we'll go on to talk about that a little when we talk about statins and about reducing cholesterol. Um, so that's the risk. Those fatty deposits. Atherosclerosis really is just a fancy term for a fatty deposit there, and it narrows the vessels. And again, um, it's all the same familiar risks as well, but particularly smoking. Now, fortunately, rates of smoking in this country have come down significantly. When I first registered as a pharmacist back in 1986, rates of smoking in men particularly were maybe around 30 to 40%. That's come down significantly over the last 35 years. And now rates of smoking vary. It does vary because it comes with sort of poorer backgrounds and other health inequalities. But generally, rates of smoking nationally are now down to around maybe 12%, something like that, as low as 5 or 6% in some populations, and maybe higher teens getting on for 20% in other populations. But as a whole, much improved. And that's one of the reasons why life expectancy has improved in this country. We have significantly cut down the rate of smoking, and smoking over those years, it does a whole host of things that are harmful to us. Quite apart from the damage to our lungs, it also increases those fatty deposits. So, risks of stroke, there are certain things, risks that are just about living. High blood pressure, to a degree, it's an inevitability of aging. High cholesterol, there's only so much that we can do about that because it's down to what our liver produces and to a degree our genetics, our family history. We can blame our parents for everything. There we go. But then there are some lifestyle issues or what might be considered lifestyle. So diabetes carries with it an increased risk of stroke because with diabetes, our blood is that thicker, bit thicker, bit more sticky, bit more likely to clog. The main reason for an increase in the number of people experiencing diabetes, being diagnosed with diabetes, is obesity. It is excess weight. And it is possible to reverse most effects of later onset or class 2 diabetes by reducing rate. Very low calorie diets have been demonstrated to reduce that. That's not to say that it's easy or that it's simple or that it's appropriate for everyone. But anything that we do can make a difference and can help to improve our risk. Smoking, of course, we've mentioned obesity because it's linked to diabetes and excess alcohol intake. And then there's one more significant risk, and that's this atrial fibrillation. So, atrial fibrillation is a fancy term for an irregular heartbeat. So, if we've ever put our head on the chest of a partner and listened to their heart, or if we felt our own pulse, we will have heard it beating regularly. Thump, 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 thump. That's what we expect to hear. As we get older, the risk of having an irregular heartbeat increases. There are certain diseases which can make it more likely, and there are certain lifestyle things, particularly again, excess alcohol, really excess alcohol. If we absolutely go on the binge, then that can cause an irregular heartbeat, affect the electrical impulses in the heart. Now, I don't mean a missed heartbeat. So once we get sort of over the age of 50, sometimes younger, we may get what's referred to as ectopic beats. So if you ever feel your pulse and it's going thump, 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 and it misses a beat, don't be frightened by that. That is not that unusual, and it's not of itself a particular issue. If it seems to occur regularly, do discuss it with your doctor. By regular heartbeat, I'm talking about something really irregular, and you'll feel sort of thump, the thump, 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 thump. It's that sort of real irregular beat. It's responsible for a fifth of everyone who has had a stroke. And atrial fibrillation, it increases our risk of having a stroke fivefold. So if I have atrial fibrillation, if I have this irregular heartbeat, I'm five times more likely to experience a stroke than a man of my age who does not have this irregular heartbeat. And that means that someone who has an irregular heartbeat, this atrial fibrillation, out of 20 people who have atrial fibrillation, out of every 20 people, one of those 20 people will have a major stroke in the next 12 months. And unfortunately, the other thing about atrial fibrillation is that it produces large clots. Because the irregular heartbeat, it's like the heart being shaken. And if I take some milk and I shake it, it will start to thicken and become cream. And if I continue shaking it, it will become thick and become like butter. And that's almost what happens to the blood in our heart. If we have an irregular heartbeat, it's like shaking the blood, and that blood thickens and we get large clots. So we have a stroke. The ambulance is called. We're taken into hospital. A number of tests will be carried out. And of course, I started off by saying that there are two different types of stroke, and they're the complete opposite of each other because a bleed is the complete opposite of a blockage. So it's important for treatment, because the treatment is going to be the complete opposite. It's important that the hospital and the clinicians work out what type of stroke we've had, because that determines how they're treated. So if we have the bleed type, then it will look at addressing the cause of that bleed, and that may be addressed surgically, or we may be given something to help the blood to thicken and help the blood to clot to stop that bleed and to address the blood that's being lost. If we have the blockage type, that ischemic stroke, then obviously we want to reverse that. So antiplatelets, that's drugs like aspirin and clopidogrel, and antiplatelets make the blood less sticky. And so often, if we've been diagnosed with one of those mini strokes, with one of those TIAs, we will be given an antiplatelet. Sometimes just aspirin, sometimes a large dose of aspirin, a 300 milligram, and then given a baby aspirin, as it used to be called. We don't give aspirin to babies now, so they're low dose aspirin. And we may be given another antiplatelet, something like clopidogrel, which is the most commonly used. We may also be given clot-busting drugs. So thrombo is the clot, and thrombolysis, that means that it's cut, and thrombectomy means the thrombus, the clot, is removed. So those are the two options, and they are very effective, particularly the surgical removal. And most effective of all, if we have had the blockage type, is to restore the blood flow by using a little device, tiny, tiny little device, looks a little bit like the sort of thing Dino Rod use. And that's inserted via a catheter in what's referred to as a cath lab. And cath labs are one of the most effective ways of treating the blockage type stroke and give the greatest recovery as well. Unfortunately, not everyone has sufficient access to these cath labs. There's not sufficient access to treat everyone who has a blockage stroke. And this needs to be done, obviously, ideally within 3 to 6 hours. And so, fortunately, living in Bristol, we do have better access because generally we are closer into a city where there are hospitals and ambulances. This sort of treatment is generally better, and the number of people treated is generally better if you live close into a major city. If we live maybe down in Cornwall or in the wilds of sort of Scotland, where everything is further away, then unfortunately the treatment times are not as good for purely practical reasons. So going on to treatments, I've talked about antiplatelets. These are things that stop making the blood so sticky. Aspirin is the most common one. Most people will be on clopidogrel. Pretty much everyone, if we have a mini stroke, we will be prescribed clopidogrel. A couple of issues with clopidogrel, and I will touch on it because someone before this talk submitted a question about a particular genotype, so people genetically who cannot get the most from clopidogrel. A lot of drugs, and clopidogrel is one example, are only effective once the body has broken them down and changed them, metabolized them into a different type of chemical. So the clopidogrel drug is in a form that's absorbed into our body, and then the body actually converts it into what has the antiplatelet effect. That's not true only of clopidogrel. Codeine is another example, and it's one of the reasons why not everyone gets pain relief from codeine, because codeine is a prodrug and needs to be converted into morphine by our body. So some people have what's referred to as a loss of function ALE, and now it's becoming increasingly common to do these genetic tests to see whether clopidogrel is appropriate for us to use. If not, we may be given one of the more modern antiplatelets, ticagrelor or prasugrel, because these are not affected by this loss of function genetic trait that some people have. However, if you're given clopidogrel, it's important to take it because it's more important to take it so that we're receiving some antiplatelet treatment. And of course, ticagrelor and prasugrel are stronger, and therefore they carry greater risks of side effects. And because we're making the blood less sticky, the carries a greater risk of us having a bleed. Even aspirin, even a low dose aspirin. This is why we say that we don't recommend people taking a low dose aspirin unless it's been recommended, because even a low dose aspirin taken daily carries a risk of a stomach bleed. Unfortunately, every medication has an advantage and a possible risk. So then, of course, we'll be on a number of blood pressure lowering drugs. And if we're diagnosed with raised blood pressure at the moment, if we're under the age of 55, we'll be given an ACE inhibitor called ramipril. And if we're over the age of 55, we'll be given a calcium channel blocker, usually amlodipine. So ramipril and amlodipine, they're the first line drugs, and it depends upon your age. Amlodipine depends how we get on with it. Most drugs suit most people. Amlodipine, we can get facial flushing, we can get puffy ankles with it. If that's too much, then we may be tried on a different type, such as felodipine, or alternatively, we may be changed onto a completely different blood pressure drug. With ramipril, that can give us a dry mouth, talking of which, I'm going to have a drink, and give us a dry throat. And so that can seem like give us a cough. And so a cough with ramipril, the so-called ACE cough, that can affect up to about a third of people on ramipril. But generally, only about 1 in 20 people find it intolerable, and so may be changed onto a different type of the ramipril version of drug. And losartan is often a very common alternative as well. Now, the reason there's several blood pressure lowering drugs, so for example, if I'm put on amlodipine and I'm given the maximum dose, rather than being having higher and higher doses of that drug, to avoid me getting side effects, I'm given what is considered the maximum usual dose. And if that doesn't control my blood pressure enough, I might then be given ramipril. And if the maximum dose of both those drugs doesn't control it properly, I may then be given a water tablet. Now, indapamide is used commonly. Bendroflumethiazide is also a water tablet, but is less commonly prescribed now. And if those three don't help, then I may be given something that's an alpha blocker. Doxazosin, again, is the most commonly used of those. And there are further blood pressure drugs as well, because not everything suits every one person. The idea is to find what gives us the most benefit, but with the fewest side effects. And if we are experiencing side effects, such as puffy ankles with the amlodipine, if we can tolerate those side effects and they're not harmful to us, then it's not necessarily a reason to stop. So the other treatments I've talked about, which is really important, is the cholesterol treatments. And so we've got the lipid-lowering drugs and the statins. And they can be very controversial, the statins, because so many people are taking statins that it's very easy for us to find people who have not had a good experience with the statins. Um, the most common side effect from the statins is muscle weaknesses or muscle aches and pains or tiredness or lethargy. Taking a statin also can bring about cataracts a little earlier than we might otherwise have had. Now, we're going to get cataracts anyway. They're an inevitability of aging. So it's not a reason not to take statins. And cataracts generally start within our 60s, and it means that we may require a lens replacement, perhaps sometime in our 70s. It's the most commonly conducted operation on the eye, very safe, very effective. So, because statins may bring on our cataracts a couple of years earlier, it's not a reason to use them because it's going to happen anyway. The most commonly used statin now is atorvastatin. And so I read a lot about them. And of course, there are a lot of newspaper articles as well. And every now and then there's a newspaper article suggesting that statins cause all sorts of untold problems. And then a few months later, you might see another news article saying that they're the best thing since sliced bread and that we should all be on them. Um, there is no doubt that statins significantly reduce our risk of cardiovascular disease, significantly reduce it. So if I have a raised amount of cholesterol, raised amounts of lipids, the first thing that will be determined is what the ratio is of good and bad cholesterol. Because our liver generates good cholesterol and bad cholesterol. And the good cholesterol can actually help to clear out those furred up arteries. So if what we produce, if we have relatively high cholesterol levels, but a lot of it is the good cholesterol, that's not as much of a problem as someone who may have average cholesterol levels, but a lot of it is the bad cholesterol. So those sorts of tests are done by surgery, by a GP, and we may be recommended a statin. Now, a lot of people say, I want to try diet. I want to bring it down through changing my diet. I'm going to cut fats out. And yes, that's a good thing to do to improve our diet. So if we reduce our fat intake, if we increase our intake of oily fish, that's very good. It increases the amount of the good type of fats we're producing, the good cholesterol. By oily fish, we mean herring, salmon, mackerel. They're the oily fish. And porridge oats are also very good for reducing our cholesterol levels. But if we do all of those three things, we might bring our cholesterol down by 8 to 10%. The other thing that sometimes we read about are these drinks, these stanols like Benecol, Flora Proactive, and the Benecol drinks. And you may often see them advertised either on the news, on newspapers or TV adverts or social media adverts, and they will often say, Chris had a cholesterol level of 6.2 and he started using Benecol drinks, and 3 months later his cholesterol level was down at 5.7. And that sounds good because it sounds like a reduction. But there's not great evidence to say that these drinks actually mean I'm significantly less likely to have a stroke. The assumption is there because it's reduced my cholesterol levels, but it hasn't reduced them a lot. So if I improve my diet and I use these sort of Benecol spreads and the other sort of plant stanol drinks, I might bring my cholesterol down by maybe 12%, which is a good thing. But if I have an increased risk, my risk may be raised 20%, maybe 30% higher than the equivalent amount of my age. And only a statin will bring it down by a third. They are that effective. And they're no longer branded. So drug companies, big pharma is not making big profits from statins. They're cheap as chips now, and they're as cheap as aspirin. So there's not a commercial reason for them to be promoted by big pharma. So the reason they're used by the NHS is because they do, and they are effective. They're another reason why life expectancy has increased. The final thing I'd say about statins, perhaps, is that if I start taking atorvastatin and I get muscle aches and pains, and I go to my doctor and I stop them, muscle aches and pains will go away. I'm taking them to stop having a heart attack or a stroke. If I have a heart attack or a stroke, the effects of that may not go away. So in a way, we've everything to gain and almost nothing to lose by trying a statin. And if the statins don't suit us, there are then other drugs which will affect our cholesterol. We can sort of reduce the amount of cholesterol that we're absorbing through a range of drugs. And now the latest thing that's been used for the last few years is an injection that's initially given every few months and then every 6 months and then I believe yearly. And that modifies the cholesterol and modifies the fats going around our body. So, a quick word about atrial fibrillation, because it is a significant risk. And as I said, it produces big clots. So, using something to stop the blood being sticky, like antiplatelets, isn't enough. We need anticoagulants, something that stops the blood from actually coagulating. Used to be warfarin. It used to be the old rat poison. Nothing wrong with warfarin. It's still used in some cases, but warfarin, the dose was very difficult, and we needed blood tests every 6 months, maybe in order every 6 weeks, sorry, in order to check we were taking the right dose. That was one problem. So regular blood tests had to be down the warfarin clinic every 3 to 6 weeks. Then every time we went to the warfarin clinic, our dose changed. So we had to make sure we were taking the right dose. And once warfarin's in the body, it persists in the body for about 5 days. So if we took an accidental overdose, we had 5 days of a high risk of a bleed. However, it is really cheap. So then about 10 years ago, there were new anticoagulants. And they're now referred to as DOACs because they're direct acting oral anticoagulants. And there are four main ones that are used now. They've pretty much all lost their patents, so they're no longer under those brands. And the most commonly used one now is the edoxaban, which I realized I've spelt wrong. There's no N in this. So it's not endoxaban, it's edoxaban. And edoxaban and apixaban are probably the most commonly used now. When they came out, they were really, really expensive. I was working with NHS Bristol at the time and working as a prescriber, and we were changing people from warfarin over to these new anticoagulants. And we knew it would cost NHS Bristol at least £2 million a year extra on top of the prescribing budget. However, the benefits to patients, it was felt worth spending that money because you don't need such regular blood tests. You may only have your regular annual blood tests. The dose is a lot more simple. The dose sticks with warfarin. Pretty much everything interacts with warfarin, including a range of foods. With these new anticoagulants, it's a lot simpler. They've got much fewer and not such significant interactions. And they're a good example of the NHS not just giving the cheapest treatment. So don't think that we're just automatically given whatever is the cheapest on the NHS. Quite the opposite. I mean, now they've lost patent, these new anticoagulants are coming down in price. So very quickly, just a bit of encouragement because everyone watching this either has had a stroke or knows someone who has had a stroke. And as I said at the start, if we've had a stroke, then by definition, we are at increased risk of having another stroke. And almost a third of us will go on to have another stroke. Now, that does include people who've had mini strokes, are at risk of going on to have a more major stroke. So prevention is important, having a healthy lifestyle. Yes, pharmacists bang on about it, doctors bang on about it, nurses bang on about it, but it does make such a difference. It's really important. We don't have to exercise, but being physically active. And when I do the face-to-face talks, I see the activity that people get from the Bristol After Stroke teams, the rehabilitation. That's absolutely excellent. It helps the brain to sort of rewire so that we learn. The brain learns new ways of moving the limbs, moving the legs, new ways of moving the muscles that help to control our speech, which is why we can recover sometimes pretty much all of our ability. If you do smoke, please stop. Only two people have to stop smoking to save one premature death. It's just the biggest thing that we can do to improve our health. Diet, like anything else, what we put in is what comes out. So if we put good stuff in, good stuff comes out. If I put rubbish petrol in my car, my engine's going to sort of choke up and it's going to stop. So the 5 fruit and veg a day, a lot of people in Europe laugh at that. Mediterranean countries would say, well, it's 7 portions a day, 10 portions a day. A couple of portions of oily fish a week is great, and obviously everything in moderation. Reduce or moderate our fat and our salt, reduce or moderate our alcohol. Right. Bizarrely, I'm going to go through the community pharmacy thing relatively quickly because it's actually relatively straightforward. We can give you information about medicines and hopefully in a way that's easy to understand. We can explain. If you go into a pharmacy and ask to speak to the pharmacist, you're seeing someone who has had 4 years at university, come out with a university degree. They have then done an additional year's apprenticeship. They have to have practice as a pharmacist for 2 years before they can be in sole charge of a pharmacy. And an increasing number of pharmacists, like myself, have been back to university to do a further qualification in order to be prescribers. And so we're seeing increasing use of prescription only medicines available from the pharmacy. You can get honest advice, reliable advice. If we Google something, a condition, then the danger is what we see is people who overwhelmingly have had a bad experience. Because if I start taking a new drug and I get on with it okay, I get on with it okay. That's fine. I'm not going to go around saying, do you know, the doctor gave me such and such a drug and I'm absolutely fine. But if I put on a new drug and I have a bad effect or I have a side effect, I want to tell everyone. So there's a disproportionate reporting of bad effects. Equally with the media, it's that thing about man bites fish doesn't make headline, but fish bites man makes a headline. We're attracted to be aware of risk. And so if we read something about the bad things, that alerts us. But within the pharmacy, we can help to put things into perspective. We can help you with self-care. There's a lot of treatments and medication that you can buy over the counter, and Pharmacy First, which is a new range of prescription-only medication, which has come in recently, nationwide, only since the start of the year. And the other thing we'll try to be is an advocate for patients. I do not understand why the NHS makes it so complicated to get a repeat prescription. It should be the simplest thing, and yet it's one of the most complicated things. So as much as we can, we will try to assist with that. And signposting basically means that if you have a condition that requires another health professional, we can advise who would be the best person for that. Or with certain of the sort of services like the Pharmacy First services, we can arrange to get you an appointment. So if someone comes to me for a Pharmacy First condition, for example, if someone comes to me for treatment for tonsillitis, for a sore throat, if I think that they have a condition that requires sort of same-day appointment with GP, we have the access numbers to phone your GP and say to them, this person needs to be seen today. And so the surgery will contact you and get you in that day to be seen. So a couple of these services, I just mentioned the new medicine service. If you're prescribed a new drug, you'll be offered a telephone call follow-up with the pharmacist for certain high-risk drugs or certain important conditions. So the staff, when handing it out, may say, it's all right if our pharmacist calls you in a week's time. And that's really to see how you're getting on with it, because research suggested that for every 6 people who were started on a new drug, only 1 out of those 6 people is still taking the drug after a couple of weeks, has all their questions answered, is not experiencing any side effects, has no concerns about the drug, has actually got the dose right. So for those 5 people who either have concerns, have side effects, or haven't got the dose right, that's the reason for those follow-up calls. Sorry, the 5 people who've got it right, the 1 person who hasn't, that's the reason for the follow-up calls. Then if you're not currently receiving treatments, you can get your blood pressure checked if you're between the age of 40 and 75. That's a specific service. It doesn't mean that anyone can just walk in and quickly have their blood pressure taken, because to do it properly takes 15 to 20 minutes. And so there are specific criteria. In other words, it's for people who are not currently diagnosed with uncontrolled raised blood pressure, people who are not currently receiving medication. And finally, one or more of you may have recently had your flu or your COVID vaccines through pharmacy. That's becoming increasingly common. Pharmacy first, emergency prescriptions. There is no reason to go without your drugs, with the exception of controlled drugs like morphine, or some of the strong pain-killing fentanyl and buprenorphine patches, for example. But for the standard medication that people would be prescribed after a stroke, if you suddenly realize you've come away on holiday without medication, or you've lost some of your medication, or you've accidentally thrown it out with the rubbish, or you've just forgotten and you've come to the last tablet in the last strip, you can get an emergency supply. You need to do it through NHS 111. If you can use a computer, the simplest thing is just to Google NHS emergency prescription. You can do it in 2 minutes. I've done it with people with a smartphone in the pharmacy. Alternatively, you can telephone NHS 111. You don't have to do it with a smartphone. And basically, it will say, who are you and where's your nearest pharmacy you want to go to? And it will send us a message in the pharmacy, and then either contact the pharmacy, or the pharmacy may contact you, may call you to determine what you need to make sure that we can actually supply it, that we've got it in stock.
It doesn't matter.
You can be supplied up to a maximum of 28 days, but it is an emergency prescription. So generally, we would supply maybe 7 days supply to give you time to get a standard prescription. But there is that flexibility. If, for example, you were away from home for a couple of weeks, so we can supply more. If you pay for your prescriptions, it's a standard prescription charge. If you're exempt from prescriptions, there is no charge. And then the other pharmacy first thing is where we can supply prescription drugs for a range of conditions. Doesn't mean that you can walk into a pharmacy and say, I think I've got a sore throat, so I want antibiotics. It's not an antibiotics by demand service, and there are restrictions and limitations. So with a sore throat, for example, probably only about, maybe 1 in 5 people that I see, I might actually prescribe antibiotics for them, because those other 4 out of 5 people, their sore throat is assessed to be more likely to be a virus instead. But there is that opportunity for those conditions. And so now, if you contact your GP, you can walk in yourself and you can refer yourself for these conditions. Or if you phone the surgery and say, oh, I've come down, my teenager's come down with a really bad earache, or I was bitten by something in the garden yesterday, or a few days ago, and it's really swelling and the swelling's not going down, it's just getting worse. The surgery will now probably say, we're going to get you an appointment with the pharmacy, and they will contact us with your details, and we will get to see you and assess you. And if we think it's appropriate, provide antibiotic or other treatment, antiviral treatment in the case of shingles. So this is my last slide, you'll be glad to know. And this is a good slide because I've been doing these sorts of talks for about 10 years, but looking back over the last 20 years, things have improved significantly. Treatments have improved. Lifestyle has improved. The understanding of how to address risks have improved. And consequently, our risk of stroke as a nation has reduced significantly. The disability, the consequences of stroke have reduced significantly. And most importantly, deaths and disability have halved. And so that's finishing on good news, really. So that's the end from me. Thank you very much, everyone, for your patience and for listening to me. And